to let everybody come in, and then we will get started. Okay, welcome everyone. Welcome. Glad you guys are here. It is right at 12 noon, so we've got a lot of material to cover. So we will go ahead and get started. Welcome to this edition of Conversation with an Expert. This is a program sponsored by the Work Group 1 Community Awareness and Education of the CJCC Statewide Human Trafficking Task Force. My name is Carla Jacobs. I am with the Georgia Commission on Women, and I am the chair of this task force, or this work group. So really glad you're here. We've got a lot of great material for you guys. This is part 3 of our understanding human trafficking from a medical professional's perspective. And the first 2 were held in September and October, and those are available on the CJCC YouTube page if you have not seen them already. So you'll want to definitely, after this, go check those out. And we're going to, the kind of a little bit of housekeeping, we are going to do just a quick overview of what was covered in part 1 and 2, and then dive into questions with our panelists. We will be using the chat to collect questions. We've got some of our own, but we want to hear from our attendees and want to really cover the things that a quick trigger warning or content warning. Some portions of this training are maybe sensitive, uncomfortable topics for attendees. Please take the time to step away if you do need to take a self-care break. We will also be putting contact information at the end of the program if you need to reach out for additional resources. This program is being recorded, so just be mindful of that we will be recording all portions of this program. So without further ado, I want to introduce all of our speakers here at the top, and then we will just dive into the program and into the questions. So our first speaker from part 1 is Angie Boy. Dr. Angie Boy is the program manager for prevention and education at the Stephanie B. Blank Center for Safe and Healthy Children at Children's Healthcare of Atlanta. In this role, she's responsible for overseeing the implementation of multiple projects related to child abuse and neglect, including child sex trafficking, prevention of child sexual abuse, and mandated reporting of child abuse and neglect. Dr. Boy also sits on several state-level work groups, including the Statewide Human Trafficking Task Force and the Child Fatality Review Project. She also works with other community organizations to address training and education needs around adverse childhood experiences. Dr. Boy has a doctorate in public health with an emphasis in maternal and child health from the University of Alabama at Birmingham, and a master's in public health from the Mercer University School of Medicine. She has over 20 years of experience in the field of family violence and has a special interest in the impacts of family violence on mothers and their children. So welcome, Dr. Boy. Thank you for joining us. We're also being joined today by Dr. Catherine Barnett, DNS RN, and she is an assistant professor of nursing at Kennesaw State University. She earned both her doctorate and master's degrees from Kennesaw State, along with a Bachelor of Science in Nursing from the Medical College of Georgia. With over 25 years of experience in women's health, Dr. Barnett has dedicated her career to caring for women throughout pregnancy, labor, and delivery. Her research focuses on critical issues like substance use disorders, human trafficking, and forensic nursing. Notable recent publications include Characters of Substance Addicted Mothers that predict graduation from a family treatment court, and Establishing a Community Academic Nursing Partnership to lead a healthcare response during a human trafficking extraction operation. Dr. Barnett's work has been supported by funding from the Substance Abuse and Mental Health Services Administration and the International Association of Forensic Nurses, further advancing her impactful research on substance use and forensic nursing. Welcome, Dr. Barnett. Thank you for joining us today.
Thank you.
Another one of our speakers who will be part of our panel is Lindsay Cheatham, and she has dedicated her career to serving victims of crime by providing a trauma-informed approach to responding to sexual assault, child abuse, and human trafficking cases. Lindsay is the state of Georgia's human trafficking victim advocate assigned to the Georgia Bureau of Investigation's Human Exploitation and Trafficking Unit. In her role, she has worked collaboratively with both sex and labor trafficking cases to ensure that the system's response is victim-centered. She serves as an advisor to the statewide Human Trafficking Task Force, State Expert Committee, and the Georgia Coalition to Combat Human Trafficking. Lindsay holds a master's degree in conflict management at Kennesaw State University. Previously, she was child and family advocate at Safe Path Children's Advocacy Center and is a certified advocate through the National Advocate Credentialing Program. So welcome, Lindsay. Thank you for being here as well. So without further ado, I am going to go off camera and turn the program over to our speakers. So I think first up is going to be Dr. Angie Boy.
Thanks, Carla. We wanted to take just a few minutes at the beginning of this session to give a brief overview of what was covered in part 1 and part 2, just to go over some of the highlights and the important things that you would want to take away from this. And I think Alina is running the slides for me, so if you want to move to the next one. First thing we want to do is get an understanding and all be on the same page with what we're talking about. And so when we're talking about human trafficking, there are two main buckets that things fall into. There's the sex trafficking side, which, as it says on the screen, is the recruitment, harboring, transportation, etc., of a person for a commercial sex act, in which the sex act is induced by force, fraud, or coercion, unless the victim is under the age of 18, in which case there is no need for force, fraud, or coercion in the sex trafficking category. On the other side, you have labor trafficking, which is the same issues related to using a person for labor or services through the use of force, fraud, or coercion for the purpose of subjecting them to involuntary servitude, peonage, debt bondage, or slavery. The difference with labor trafficking is you have to have the force, fraud, or coercion. There is not that separation by age. So if you want to move on to the next slide. You may, within the field of child sex trafficking, hear domestic minor sex trafficking and the commercial sexual exploitation of children. At their core, they mean the same thing. It is the trafficking of children for sexual activity. The difference is that DMST is concerning a person who is a U.S. citizen or lawful permanent resident under the age of 18, whereas CSEC is any child who is a victim of sexual activity in exchange for something of value. In the healthcare field, we usually use CSEC as the term because healthcare providers are treating all comers. Other service providers may have limitations on who they can serve due to grant funding or other reasons. And so they will focus their work on those children who are victims, those victims who are U.S. citizens or permanent residents. But in the healthcare field, you will almost always see it called CSEC. Next slide. One of the big things that we want you to take away is the reporting process and the reporting structure in the state of Georgia for human trafficking. In Georgia, all child sex trafficking must be reported to the Division of Family and Children Services. So you have to call the 855 GA Child number to make that report. It is considered a form of sexual abuse in Georgia, and it is required to be reported to DFACS. You should also make a call to the human trafficking hotline to work to get the victim connected to services. So you really, on these children, are making 2 phone calls, but that call to DFACS must be made. Next slide. The difference is with adults, you are not required by law to report adult sex trafficking. You only have to report when there is a vulnerable or at-risk adult. So this would be somebody with mental or physical disabilities or an adult 65 years or older. And those calls go to Adult Protective Services. You are not required to contact law enforcement if you have a victim of trafficking in an emergency department in a clinic setting. In fact, because Georgia does not have that reporting requirement, to contact law enforcement is actually a violation of HIPAA because the victim has not asked you to make that contact. You are letting someone know that they are seeking medical services and you don't have their permission. Now, we encourage victims to report, but there is no requirement. And aside from it being a HIPAA violation, you are taking the autonomy from an adult, and that decision may be the only control the victim has over their situation. So you then taking that control from them is removing that autonomy from them, and they may refuse to talk to anybody who shows up. They may try to run from the emergency department or the clinic, and then they're not getting connected to any services, and they may refuse to come back and seek services. And so you're potentially putting them at risk for further harm. So the important thing is, if they are not a vulnerable adult, you do not have to involve law enforcement. Next slide. Some of the common misconceptions around trafficking, we list them here. One of the big ones that we hear a lot is that only girls are victims, or there are no male victims, or males don't want help, that kind of thing. We know that victims cross all spectrums. It is not just poor people, it is not just immigrants, it is not just females. Traffickers, just like that, traffickers can be anybody. Uh, Not all traffickers are male. Not all um, buyers are male. So that's important too. We also, people will still to this day say, oh, human trafficking, that happens overseas, or that's something that happens in, Eastern Europe or in Asia. But human trafficking is happening in the state of Georgia on a daily basis. So this is something that is important and is an issue in the United States. Another thing that we will hear is that youth choose to get involved in the life. Aside from the fact that youth can't consent to commercial sexual activity in the state of Georgia, no child wakes up and decides that they want to sell themselves for sex in the morning. And that's just what they're going to do. That's how they're going to make money. That's how they're going to provide for themselves. That's not how it works. They may feel like they've made the choice because they are, following through on the steps, but there are other things in life that have gotten them to the point that they feel this is their only option. So no, they are not choosing to get involved. Another one is that you have to have force or coercion to be victims of human trafficking, regardless of age. Like we talked about, if they are under the age of 18, they are automatically considered a victim of CSEC. Trafficking victims are not always going to be eager to be rescued. Oftentimes they may be very hostile to help. That doesn't mean they're not deserving of help. That doesn't mean that on some level they don't want help. But this is a protective mechanism. So the important thing is to make resources available to let them know that you and your organization are a source of trust, and provide that information. And then obviously, if you are required to report, you want to make those reports. Trafficking happens throughout the state of Georgia. It is not just a Metro Atlanta problem. The Georgia Center for Child Advocacy that runs the CSEC response team has victims from all over the state that they work with. This is not just a Metro problem. And then the idea that relatives can't be traffickers. We see cases all the time where the entry into trafficking was familial, that a parent will provide their child for sexual activity in exchange for a car payment, or in exchange for rent, or in exchange for drugs. So we do see a good bit of familial trafficking. And since the pandemic, we have actually seen an increase in the number of familial trafficking cases that have gotten identified. Next slide. And like I talked about, that is one of the pathways to entry for trafficking. According to the Polaris Project, 26% of their reported trafficking cases were familial in origin. And that's not just Georgia, that's their national numbers, but we don't have any reason to think Georgia's numbers would be any different. So in 26% of the cases, it's a parent or caregiver who are facilitating the trafficking. It could also be related family, but it is generally someone who has direct access to the child on a regular basis. Another 22% were trafficking that was initiated by an intimate partner, or that so-called Romeo trafficking. So these are intimate partners who are facilitating the sexual activity and are usually the ones facilitating payment and things like that. But then we also see recruitment via social media, particularly the apps, TikTok, Snapchat, Facebook, Instagram. We see some via sextortion, where they may use intimate pictures and then extort money or other sexual activity from a person to try and prevent the photos and images from being shared. False employment, we see that a good bit, particularly with labor trafficking, but we will also see it in the sex trafficking field as well, where a job is promised and then the person may come to a location and they're in a job, or the job is very, very different than what was promised. And then we also see peer recruitment. Schools are one of the big recruitment grounds for CSEC. The victim will go in and recruit their friends to the same kind of activity that they're involved in. So we see a good bit of peer recruitment as well. Next slide. Some of the just ideas around who the victims are. We know they can be adults or minors. They can be foreign nationals or U.S. citizens. Any gender identity is represented. So again, this just gives you an idea of the wide variety of victims that you will encounter. Some of the vulnerabilities that may make a person at higher risk for being victimized if they are homeless. This is particularly a concern for male victims. They may be, excuse me, thrown out of the house as a teenager and they don't have a way to survive. And so they are more likely to engage in what is termed survival sex. But homelessness is a big risk factor. Presence of prior abuse or violence, particularly sexual abuse. More than 90% of child trafficking victims have a previous history of abuse. If they have a temporary immigration status, if they struggle with substance abuse issues, poverty, mental health concerns, family dysfunction, again, particularly abuse, raises the vulnerability and raises the risk factor for being trafficked. Next slide. Some of the more specific risk factors for sex trafficking, again, I mentioned the physical and sexual abuse, prior child abuse. If they're in a socially marginalized group, they may have increased, again, vulnerabilities. It's a high risk factor for homelessness. And then if there's a history of being involved in a system, whether it's juvenile justice or foster care, there's a greater risk for being trafficked sexually. On the labor trafficking side, you do see the physical and sexual abuse as a risk factor. Immigration status is a big one because victims are often at the mercy of whoever has helped facilitate their travel or getting to the location they're in. They may take their documentation if they are documented, and then they will use their immigration status as one of the control tactics. Again, we've already talked about homelessness and poverty. Diplomatic immunity for certain employers. So the employer may have diplomatic immunity, and so their behaviors, they are protected from criminal prosecution And so they may utilize more difficult, they may, keep somebody uh, in very poor conditions, force labor for, close to 20 hours a day, provide very little food, again, maintain that documentation. They know they have that immunity, so there's less concern about their behavior. And then lack of employment or labor opportunities in a home country may lead someone to attempt to come to the United States, and then their immigration status, again, as a risk factor, but they are willing to take those risks because the situation is so dire in their home country. Next slide. All right, I'm going to turn it over to Dr. Burnett.
Hi, everybody. So starting about looking at the medical assessment, as a healthcare professional, it's really important, foremost, to create a bond and a rapport with those patients, right? We know that it takes maybe up to 10 times for a patient who is experiencing human trafficking to ask for help or to let us know that they're being trafficked. So it's really important to build up that rapport first and foremost. So I want to talk about behaviors of what we see and what we should be looking out for as healthcare professionals. So defers or seeks permission from a person accompanying them. A lot of times in the hospital, we will see that these patients don't want to make any of their own medical decisions. They turn to someone in the room or someone speaks for them. Uncomfortable leaving without the escort. They know that the trafficker might punish them if they go off without them. So they feel uncomfortable going out of the room with you or talking to you in private. Unaware of the address. A lot of times we hear people will tell us they don't know their address, they don't know their phone number. Not having a phone in this day and age, especially with young people, is usually an odd thing. So if they don't have a phone number, or we're seeing two phones a lot of times with some of these individuals where they have multiple phones. So any of those can be a red flag. Hypervigilance, overly complicit to practitioner. They just want to please you and get out, kind of thing. They don't have any voice for themselves. Demeanor, fearful, anxious. We see this a lot at a recent human trafficking operation I was at. One of the patients just kept expressing and crying that she was going to be punished for being there with the healthcare professionals because she was worried she would get in trouble from her trafficker, really at a high level of anxiety. Body language, that they're fearful of you, they don't trust you, they have trust issues, and that's just been from the lifestyle they've been forced into. Appearance changes. Over time, we see them going maybe changing their appearance as they've been trafficked more and more, and as their trafficker kind of demands them look a certain way for the situation. Doesn't have possession or control of identity or any identifying documents. We see this a lot. They don't have a birth certificate. They don't have a driver's license. They have no way to show who they are. And that's because all those documentations have either been taken from them, especially in labor trafficking. We see a lot of times their passports and other documents have been taken away from them. Or it might be when they were pulled or extracted out of their family setting, they didn't have those documents to come with them. A lot of times they have very little personal possessions, even something as simple as a toothbrush. They might not have pads when they have their period. I mean, it's crazy as few possessions as these women and men might have. And then unexpected material things. Sometimes we see the trafficker buying them things, trying to win them over with material things. And sometimes those come up unexpectedly. And that can be also a sign as a medical professional to maybe ask a few more questions. Verbal cues, just visiting. We get this a lot with our human trafficking that are being maybe moved from place to place, or maybe they are staying there, but they don't know their address and they're trying to come up with a reason why they don't have an address. They can't give you a lot of stuff. They're just visiting. Suicidal, homicidal thoughts. We see this a lot with individuals who've been trafficked that have experienced a lot of abuse and both physical and emotional abuse, and they just want to harm themselves to kind of get it over with and stop living, unfortunately. Vague background goes back to the just visiting, like they're trying to keep everything really vague because they don't want to trigger you that you figured out that they are in a trafficking situation. Language barriers, we see a lot of times. We saw this a case recently in the hospital where the patient and the trafficker were both speaking in a different language, and it ended up that the nurse knew the language and they didn't realize the nurse knew the language they were speaking, and the nurse picked up on trafficking language, that they were using a different language to kind of talk behind her back, but she fortunately knew the language and picked up on it. We'll also see we've seen a couple of cases of women who have said they were deaf or hard of hearing and then turn it over to their partner to communicate with them. And in fact, they weren't deaf, but they were trying to not answer questions and leave that up to their trafficker. Again, refusal to use interpreters. That's okay, keep going. No healthcare. We see this a lot, or haven't gotten healthcare in a long time. No prenatal care in our women that are pregnant. Those kind of all things we need to ask more questions. Malnourishment and neglect. A lot of our women are skinny and malnourished, sometimes because of the substances that they've been put on by their trafficker. So they've lost a lot of weight, sometimes because they've just not been fed by their trafficker and they haven't had access to their own money to feed themselves. Multiple sex partners, you can imagine, physical exam that doesn't match the history. Things don't add up. Those red flags is what you want to be watching out for. There's a lot of branding and tattooing, and we have some great experts in this area with the CJCC. So if you ever need to call the human trafficking hotline and ask about something that seems suspicious, they're definitely there for you. And then physical injuries that just don't make sense. All right, moving on, Alina. Thank you. Okay, starting what I reviewed in Conversations with an Expert Part 2 is the medical team that I helped develop here in the state of Georgia with my team. And so I wanted to just do a quick overview. What the Criminal Justice Coordinating Council determined after a few labor and sex trafficking operations handled by the Georgia Bureau of Investigation and Homeland Security was that we really needed a medical team on site during these human trafficking operations. That a couple things would happen. One is the patient's medical needs needed to be met, those urgent medical needs. Two, medical team could be there to triage who needs to go to the hospital, who's okay to go on to a non-government organization, or these adult victims, some may choose to go back to their trafficker. So we need to provide that care. We also are building that rapport so that even if they do decide to go back and return to their trafficker, that they will build that rapport. And when they're ready to get out of trafficking, they will trust those healthcare professionals and they will seek us out. Sorry, Alina, keep going. So Sarah Pedersen of the CJCC came to me and I built a multidisciplinary team. And working with the GBI, the FBI, and Homeland Security, I reached out to a local nonprofit organization, Bethesda Community Clinic in Cherokee County. And nurses here at KSU, nurse practitioners and nurses worked with Bethesda. Bethesda has the lab equipment and the medications and the physician oversight. And our nurses and nurse practitioners, we built a team to attend these human trafficking operations and provide care on site when we recover individuals. You can go on to the next slide. Thanks, Alina. So our first one was in College Park. We were actually given a conference room right next to where the operation was going. You can see we set up everything thanks to Bethesda and their equipment and our manpower. We set up tents in a conference room. You can see the tables. We just made a makeshift triage center. Interestingly enough, that was our first, the first one I was involved with, and we have really transformed what we're doing. We've moved from the hotel conference room. We've moved into Bethesda as a mobile unit, and we've tried doing it in a mobile unit, which has been a really great space. But we realized that when we move it away from the operation, the further we get, the less patients are interested in that free medical care. So the last two operations we've actually done on site in a hotel room. So if you can imagine me taking all of that equipment you see in those pictures and shoving it into a hotel room, it's pretty interesting. But we've learned what is really most important and what's really needed the most, and minimizing the equipment to provide the care right there on site. And it's been really great because the last two operations we've actually, in addition to caring for these individuals, we've also had several medical emergencies on site that we've been able to respond to while we're waiting for paramedics to get there. So it really helps being on site right there, able to provide that care. All right, next slide. To talk about our team, I talked about we built that multidisciplinary team where we worked with our community partners, we worked with our advocates, On my end of the team, on the healthcare side, we have advanced practice nurses and doctors that are providing the care. We've also found that telehealth works really well. It's hard. These human trafficking operations go a lot of times way late into the night, 2 and 3 and 4 in the morning, and it's hard for nurse practitioners and physicians to take time off from seeing patients during the day and give time for the operations. So we found that we can do telehealth and we can divide shifts of 4-hour shifts if need be into the middle of the night, and it makes it much more doable for our advanced practice nurses and physicians. Mental health experts, nurses are really important. There's a lot of de-escalation going on for these victims. They're scared. They've been abused and mistreated, and they're scared. The police are involved and they're scared. So being able to provide them an expert to help them walk through that is really helpful. Sexual assault nurse examiners, we've had at every operation that we've done. Interestingly enough, most of our adults do not see them as victims of sexual assault, even though we know they have been exploited in that way. And we have not been where those sexual assault nurses have had to do an exam, but we're ready in case we get a youth or an elderly or someone that wants one. And then nurses with expertise in substance use disorder. I have a background in substance use disorder, and I've used that expertise a lot in the operations, that motivational interviewing, that brief intervention that we can provide right there on site to get them to start thinking about possibilities, and then provide them the resources of where they can go if they do want further treatment. Okay, next slide. And if you'll hit the button again, Alina, the little words pop up there. I think, yep, there we go. It was really important to me in the first human trafficking operation where we provided medical care to take care of the patient's comfort needs. We knew based on historical data that they do not have a lot of their own personal belongings. So I feel strongly that the only way to care for somebody is to meet those physiological needs first. So food and drinks, a lot of them, like we said, had not eaten, but I also wanted them to walk away with a bag full of fuzzy blankets, fuzzy socks, hygiene kits with toothbrush, toothpaste, shampoo, pads, tampons, contact cases for girls that had contacts, anything that I could, which would benefit them if they decide to go back to the trafficker, or if they decide to go on to a non-government organization or off on their own. Anyway, they would have this bag of comfort items. So I've collected all this, and we give those out at each event. All right, next slide. Here are 5, 1, 2, 3, 4, 5. Yeah, 5. We've actually done 6 now. Just a quick overview. I won't go through it all, but kind of the care we've given, locations, number of girls. You'll see the January of 2024, 0. It ended up that operation just did not have any victims. It wasn't that 0 chose care. It's just that there weren't, it ended up we didn't have any patients that time. And these numbers are on the low side. Some of these we attended to more people, but they didn't choose to have full care, and so they weren't counted. All right, we can go on to the next slide. And then talking about that multidisciplinary team, which is so important between Homeland, Georgia Bureau of Investigation, law enforcement, FBI, and then kind of our medical team, which I've talked about. And then the other side, the advocates, the survivors that come and talk to the patients are really, really helpful to share their own story and let those patients see kind of what opportunities lie ahead. Those non-government organizations that will provide housing and other resources to the patients. And then, of course, the Criminal Justice Coordinating Council, which I wouldn't be here if it weren't for them inviting me on this journey. All righty, I think that's it. Dr. Boyd, back to you.
Yes, we also just wanted to make available again the resources that we provided. I know in the first session, I think a similar set of resources were available in the second, but the first is the Children's Advocacy Centers of Georgia. That is the group that runs Georgia's CSEC response team. They are the ones who are facilitating the statewide coordination and response to the commercial sexual exploitation of children. They respond on the 24-hour hotline, so they are answering those calls where there is a child trafficking concern. Their team works to do a comprehensive assessment and then build case plans and do case management with both the victim and any guardian or parent. They will help facilitate forensic interviews and specialized medical exams when necessary. They also do advocacy. They have access and the availability to connect victims for intensive therapy. And then they have additional referral options if necessary. And so they work with all of the different child advocacy centers within the state of Georgia. The Blank Center is one of the CACs in Georgia. So they help coordinate the response throughout the state, utilizing the services in a lot of instances at the child advocacy centers. Next slide. So we are, like I mentioned, one of the child advocacy centers. We, as a child advocacy center, provide that multidisciplinary approach to the investigation, treatment, and prosecution of child maltreatment, including child sex trafficking. We at the Blank Center are both nationally and state accredited. We provide those medical services both in our emergency departments and in our clinic setting. So we can get the child connected to additional medical resources if needed. Excuse me, provide STI testing and follow-up, things like that. We also, as a team, provide inpatient care when necessary, and then see patients in our outpatient clinic. One of the most important numbers to walk away with from this presentation is the 866-END-HTGA. That is the hotline. There's a website as well that connects victims to services. So it's a phone tree option. So if you want to leave a tip at the GBI, there's an option for that. If you need to get a child victim connected, that's option 2. Adults, option 3. I mean, you can go down the list, but this number excuse me, cuts out the middleman of having to call the National Human Trafficking Hotline and then being connected back to the Georgia hotline. You can use the Georgia hotline. Again, this is operated 24/7, and it really works to help coordinate care for victims. Next one.
That's it, Angie. Thank you.
Perfect.
Awesome. So real quickly before we get into questions, Workgroup 1 created a resource for our healthcare professionals, and we're going to have April Carr, one of our workgroup members, come and hop on and explain this to you guys. April is an RN at Doctors Hospital in Augusta, Georgia, and a sexual assault nurse examiner with the Sexual Assault Response Center, also in Augusta. She's a member of Workgroup 1, and she led the project to create this decision tree / flowchart / algorithm, pick whatever term you like, for healthcare professionals, and she's going to go over that with us. April.
Thank you. Can y'all hear me okay?
Yes.
Okay, great. So when tackling this project, we just kind of wanted to have some kind of format for medical professionals to follow for any suspected trafficking. And being a former ER nurse, I know how much we love algorithms. That is a quick layout of steps that doesn't take too much time for us to have to read or a process to go through. So we just wanted something at a quick glance. So this is how we came up with this. So we'd have the red flags to look for when they come into the ER, and not necessarily just the ER, it could be any medical facility. I'm just speaking ER because that's my biggest background. So red flags to look for, and then if these red flags, if you suspect them or they're evident, then you would discuss with the patient some questions, try to dig a little bit further, obviously without putting them in more danger or not gaining trust. You want to gain their trust for sure. So once you ask some questions and feel that you need to, you can call in other people to help, the social workers, the SANE advocate, whoever you need, interpreters if needed. And then obviously if there has been something done with the minors, you would definitely have to report them. That's mandated reporters. Adults, as she said earlier, we do not have to report that, but we can strongly suggest to the patient that they call the hotline, and that will walk them through the steps And then we also added on there a QR code with all the resources that they would need if they chose to seek more help. That's about it. It's pretty straightforward. It's just we wanted something quick and easy for medical professionals to be able to look at it at a glance and keep on going.
Awesome. Thank you so much, April. And
Yes, ma'am.
I really appreciate the work group 1 did on this and creating this resource, and it will be provided to you guys. We're going to be sending out a follow-up email with links to the survey and certificate of attendance and all of the resources that we have gathered. It's 2 or 3 pages of links to resources if you need additional training, or if you just need additional information, and this will be a part of that. So we will open the floor to questions. So we've got Dr. Boyd, we've got Dr. Barnett, we've got our victim advocate, Lindsay Cheatham, and wanted to open it up to any questions you guys might have. So if you want to pop those in the chat, we can do that. While you guys are thinking, we will, I'll just ask one of my questions, and that is, what differences do you see in healthcare needs of survivors of labor trafficking versus sex trafficking?
I think I talked about this on the last one, so I'd love to share again. I think what we have seen in our situation is a lot of our labor, a lot of the symptoms can be the same when we talk about signs and symptoms, but when you look at the physical assessment part, some of our labor trafficking victims have been more exposure injuries to outdoors if they've worked outdoors, or manual labor, like really tough living environments. Our sexual trafficking patients have tended to have more STIs, urinary tract infections, yeast infections, those kind of things. But your labor trafficking can have those same symptoms, because we know a lot of times our labor trafficking victims can be sexually abused too, and vice versa, right? And our sex trafficking victims can be made to work in labor type situations. So they're definitely crossover, but we do in our big labor trafficking here in Georgia, we saw a lot of sun exposure, injuries, chronic injuries to bones and muscles because they were bent over so long or they were digging so long, those kind of injuries. But know that they can kind of cross over, because we know that it can happen both ways, and not just to label one set here and one set here, but a lot of times they have similar symptoms. Awesome.
Thank you so much. So here's a question I get when I do training across the state with any group. And that is there a system to determine the age of a victim or someone that is in front of you? How do you determine whether they're a minor or not?
That's a great question. For our operations, we're lucky to have law enforcement with us. So law enforcement does the background and tries to identify who they are and has their own mysterious ways of how they do it all. I'm not randomly out there, so I don't know if Dr. Boyd has any other advice that I'm not thinking of.
Yeah, generally by the time they come to us, we know they are a child victim, because law enforcement just will assume at certain points. One of the things that we have just always advocated for is, if you have concerns that this is a child victim, make the report, and they can determine when they are doing their investigation, oh, this person is actually over the age of 18. It's not a defects issue. But if there are those concerns, the important thing is to make that referral and work to get the person connected to services, regardless of how old they are. But you make that report to defects in the event this is a child under the age of 18. But there's no real good way to identify whether or not they are over the age of 18.
Excellent. Thank you. So let me ask, I guess, Angie, Dr. Boyd, In part one, you mentioned that 26% of reported cases were familial trafficking and 22% were linked to intimate partner trafficking. What are the red flags of familial trafficking or intimate partner trafficking?
The red flags are very, very similar. The issue with familial trafficking, again, you're going to have the person who is making all of, answering all of the questions, is that sort of dominating person in the room is a family member. If you've got family that, if it's a non-custodial family member, so maybe the uncle has brought them in for care or things like that, the concerns would be, why is uncle bringing them for care versus their primary caregiver? Those kinds of concerns, you need to be asking some more questions about what's going on, what's the dynamics of the relationship, where, how is the uncle the one bringing the child in, those kinds of things. With intimate partner, it's going to be harder because it is the same kind of red flags that you would be looking for in an intimate partner violence relationship. You are going to see some of those same dynamics. You just have the trafficking component added in. So again, those power and control dynamics, the dominating person answering all of the questions instead of allowing the patient to answer the questions, those kinds of things.
Okay, thank you. We have a question in the chat. Let's see, I'm the CSEC training administrator for CACGA and often give trainings in the medical community. Is there a particular screening tool that is recommended? I believe Wellstar uses PCAST, but I'm not familiar with others.
Great question. I want to also introduce Sarah Pedersen is on the line, and she is the state sexual assault coordinator for Georgia with CJCC. And sorry, she was called to a meeting this morning and has come on the line. And so I just want to introduce everybody to her, and she might be able to help with some of these questions too. So I wanted to let y'all know that she was here too.
Thank you so much, Dr. Barnett. And actually, I'm rereading that question. I was just logging in and getting all my audio up. The question was, any other CSEC screening tools that are available? Was that what we were asking? I think the one we're all familiar with that we talked about in the training also was Jordan Greenbaum's screening tool. And then there's also other validated human trafficking screening tools. And I believe that Dr. Boy and I had that in our resources. I can try to pull that up, where we did bring you to the link where you can access different tools. And there's different tools that can be applied to different settings, whether it's the age of the population or where you are in practice, or if you're looking for a quick screening tool or a more in-depth one. So let me try to pull that up right now, and I'll at least drop what I do have for the link to go access those variety of the validated tools. But the Greenbaum tool that she did in collaboration with Dr. Marnie Dodd is one that I really like because it's quick. And when you look at the 4 different things that are really carried through how they introduce the screening, it's applicable, I think, across the patient population. And those are things we are trained to do in general in nursing, is introduction to self, what your role is, empowering the patient, discussing limitations of confidentiality, and then closing things with what questions do you have for me?
I think that is included in the list. Is that correct, Alina? That several different screening tools.
It is included, yes.
Is included. Okay, excellent. So those will be part of the resources that we do send out.
Wonderful. Okay, good.
Any other questions from the chat? So I'll ask this one. For the statewide human trafficking operations that Dr. Barnett talked about, how can an individual get involved in those to assist?
That's a great question. I'll start, and then I want to turn it over to Lindsay and make sure Lindsay can talk from an advocate perspective too. When I started this role, when Sarah asked me to put a team together, As I mentioned earlier, my biggest concern was comfort items and to make sure that the physical and emotional needs of the patient were met first, and then they would be more open to receiving medical treatment. And so putting together hygiene kits, comfort kits, I think is where anybody in the community could start. So in my area, some of the high school clubs have started doing it. Some of the Girl Scouts have done it for projects, but putting kits together with shampoo, conditioner, soap, body wash, toothpaste, toothbrush, those basic things. And if anybody's interested, feel free to reach out to me, and I'm happy to share a list with you that I have. Pads and tampons, blankets, stuffed animals, fuzzy socks, food for operations, anything like that. People want to help, and it's amazing. They just don't know how. And so those are great ways for people to help that aren't on site, but are doing just as much impactful work as we are as healthcare professionals. And then we are trying to regionalize our efforts. Sarah and I can only go so far and do so many things at a time. And so we've been trying to do the big operations that have come up, but we would love to develop regionalized teams. So Sarah and I've had to travel like down south towards Savannah, and obviously that's hard on our schedules. So we're really trying to regionalize where we have teams that are familiar with the resources in their area and can go out and do kind of the same kind of work we're doing, maybe on a more local level. Lindsay, can you think of other ways people can get involved, like from an NGO perspective or a?
Yeah, those are all great. The hygiene packs and comfort items are huge. I was gonna second the blankets. We've had a lot of cases where either trauma response of the women, their bodies are shaking because they're cold and scared, come in with inappropriate outfits for the weather time of year, especially this time of year. We've had, I feel like each operation we learn something, and we always are adapting and running out to CVS or Walmart, whatever, to pick up items. And so that list is ever changing. But I love the idea. The hygiene bags that we give out and the care items is great. But I know in the past we've had churches and organizations donate like the handmade fleece tie blankets, which would be great because a lot of times I'm just ripping a blanket off of the bed in the hotel to wrap them around or use my own jacket or whatever like that. So if we could find a group that wanted to do those little hand tie fleece blankets, or if someone's more creative than I am with knitting or quilting, whatever, those are great. We always have stuffed animals, even for adults, just in case they need a comfort item or something to just hold on to. I've had a case in the past where the stuffed animals came in use with an adult because she recently had a miscarriage, and it was just one of those things where she could hold on to it and have that comfort with it. So I will drop my email might be in it, but I'll drop my email. And if you're interested in starting one of those programs or anything like that, we can connect. And the best thing would be for me to just connect with you before we go on these operations, and we can meet up somewhere, get the items, and just keep you up to date with what items we're lacking, what we need more of, things like that.
Okay.
And I dropped
go
my
ahead.
email in there too. So Dawn, in response to that, feel free to email Lindsay or myself.
Excellent. Thank you. So I'm going to combine two questions here. What are your recommendations on how to navigate when an adult discloses they're a victim of trafficking, but does not want to report to law enforcement? And then also the question from the chat, does anyone have additional resources for trafficked adults? I'll throw that out there.
I'm happy to speak to that one unless Dr. Burnett or Dr. Boy had wanted to take that question. Okay, so to my knowledge, and remember I have no law background, but to my knowledge, that falls into a couple different considerations. We do have the non-accidental injury report if we are caring for a patient and there are injuries or things that are not explained by their history or consistent. Those are things that we can report. So in the context of responding to the adult, if you're seeing some of those non-accidental type of injuries or concerns with what you're seeing in the assessment, those can be reported. However, my understanding is it falls under the same thing with that exploitation language in the mandated report I'm not sure if Dr. Barnett shared that slide earlier with the elder abuse, but it shared that statute that goes into the mandated report for under 18 up to 65 or with a disability. So it would be similar to that. And the patient still has some of those same rights. But again, I would consult with your own teams and understand what your protocols and the expectation for response is when you're seeing an adult. But the adults fall into that same type of response that any patient that's coming in for sexual assault would be, with that caveat of non-accidental injuries if you're making a report under that.
Okay, excellent. Thank you. How about any like resources for adult victims? Where do you, I guess that's a Lindsay.
I can take that question. We have a lot of different resources throughout the state. It depends really if you're looking for residential or community-based resources. Really anything that might pop up, I can help connect to. A lot of hospitals have our the hotline number. Option 3 will come to, right now it comes directly to me. And I help hospitals and nurses all the time that call and they are like, hey, I have a patient who's a trafficking victim. They don't want to report, but they have nowhere to go once they're discharged from the hospital. So working with the hospital system is something I do often to just look at those options for either placement or outpatient mental health services. I work very closely with your hospital's social workers. A lot of times they are highly trained with like the homelessness and domestic violence aspects, but might not have as much information on resources for trafficking victims. So feel free to pass my email along, as well as the state hotline number, which we will have at the end of this, is a great option just to kind of get those additional resources that might not be medical specific. But obviously when they come in, they might have a list of their electricity is getting turned off or their child doesn't have school supplies, really anything that might pop up. If you feel like there might be something that we can connect them with, reach out to the hotline and we can directly connect them with those different resources.
Okay, awesome. Thank you. You'll note in the chat that Elena has dropped in a survey and also dropped in a certificate of attendance. We are coming up on 1 o'clock, so we'll see if there are any more questions from the audience. We can go over a few minutes if that works for people. Are there any more questions? Want to make sure that we get all of your questions. Any more? Okay, so I think we'll wrap this up. I want to thank all of you guys, Amy and Kathy and Sarah and Lindsay and April, who gave us your time today and did all the prep work that was needed to put all of this together. We appreciate you guys for parts 1 and 2 and 3. So looks like there is a problem with the certificate. It will also be included in the email that goes out tomorrow if anyone's having difficulty accessing the certificate. Yes, you will be able to re-listen and watch this as soon as it is put on the CJCC YouTube page. We will make that available and send that out to attendees so that you will know how to access that. We'll include links to parts 1 and 2 if you missed those. Let's see, email with resources will be coming after the meeting, probably in the next couple of days. So you'll have links to all the resources we've discussed and even more that we did not even get to today. So we've tried to collect everything you could possibly need as a healthcare professional in the state of Georgia when it comes to human trafficking in one spot. So we appreciate you guys. We appreciate, this is our last one of the year, and we appreciate you guys hanging in there with us and attending these, and appreciate CJCC and appreciate Work Group 1. So with that, we will sign out, and thank you guys for coming.